Okay, today I got the honor to interview Peter O'Sullivan, who is one of my PhD supervisors as well. And he probably doesn't need more introductions, but the first question that I got when I asked Finnish colleagues for questions was, of course, can you tell me your story?
Okay, so my story began in New Zealand. So I grew up in New Zealand. I was youngest of a family of 6 people. I was the youngest of 6 children. I grew up in an environment where I was very active and, was encouraged to be active. And I never, I had a parents who probably didn't give a lot of attention to me hurting myself and stuff. So I'd fall out of trees and my mother would send me to school. I remember one day going to school with a broken arm, going, I'm really got a sore arm. It's like, you'll be fine after you go to school. So I've still got a sore arm. And then 3 days later, I got x-rayed and it's like, oh yeah, you've got a broken arm. So I think that's a pretext to my story, and that I kind of grew up in an environment where there probably wasn't a huge attention paid to pain and health and injury, I suppose. It was just presumed that you just got on and you got engaged with life and you stayed active. And then towards the end of my schooling, I was like, what am I going to do with my life? And I had an interest in either going down an arts direction or into a health direction. And then by chance, I just applied for physiotherapy because I thought that was kind of like something that looked kind of interesting in terms of like it utilized the human body and it was kind of health, but it wasn't, like medical. So I just kind of ended up doing that. And I remember at the end of my training going, ugh, what have I done? Because I felt like I just got taught a load of stuff that had no evidence base behind it. And that was very concerning for me. And it was really at a very early stage. This is like the late 80s, where there was very little evidence of physiotherapy. So a lot of the reading that we got was just stuff that people wrote, no evidence at all. And I was spending my time in libraries looking for any research I could find and basically arguing with my lecturers. And I must have been a real pain in the ass because I basically questioned pretty much everything that I learned. And I really loved things like anatomy. I really enjoyed, I loved anatomy and neurology, and I was interested in movement and stuff. So that was kind of like my first stage. And I actually applied medical school pretty much when I graduated because I was like, I can't do this job. This is crazy. There's no evidence behind it. I feel like I'm really doing something that has no evidence base. And when I had my interview, they said, look, we don't really keen for you to just jump from one thing to another. Go away for a year and then come back to us after a year. And I was really lucky that I worked in an environment that first year where I kind of had I had some insights that what physio could be. So then I basically spent the next 3 years working with some really very skilled manual-therapists who had a real interest, and they were very skilled at handling and really interested in taking the profession further forward. And I did every workshop I could do. I could crack any joint in the body, and I was, really good at doing Mulligan techniques. I've been to all the McKenzie workshops, and I had a very biomedical, structural understanding of pain. And then I was like, I felt like I was treating symptoms and not really understanding what I was doing, and that really concerned me. So I looked at doing more training. And so I ended up going to Australia to do my manual therapy training. So I'm doing more manual therapy stuff. And my first job after I did that training, I had 2 jobs. I worked with Bob Elvey, who was a very skilled practitioner, and I worked in a pain management clinic, and I saw all these completely disabled people where manual therapy had been tried and failed. Where they were really fearful and highly sensitized, and people you couldn't even touch. And I was like, and then I was working in a private practice where people come in and they've got a stiff neck and I crack it and they feel better and they go out. And I was going, hang on a second, I'm treating a lot of well people who've just got aches and pains, and there's a lot of really disabled people who manual therapy just doesn't work for. That concerned me. And then I was looking at the evidence base and going, there's no evidence for what we do. So I then embarked on a research journey, which is really to look at developing myself as a researcher, investigating people with back pain. And that journey's kind of extended from like early 90s really right until now. And that journey's been like a metamorphosis of seeing pain as structural biomechanical to seeing pain in a very broad context as a biopsychosocial phenomena. And that's been a parallel journey where I've continued to work in clinical practice, where I see people every day who are disabled with pain. And in a clinical setting where we're researching the clinical journey of people's pain. And that's like my parallel world now, where it's kind of completely flipped the way I see the world, I suppose, but utilizing key skills that I probably developed early and adopting them in a different way.
Yeah.
So that's a snapshot of my journey. And I suppose parallel to that is my own personal journey of having injury, of having pain, of having tissue damage, of you know, whiplash, broken bones, you know, being told body structures were wrecked, and you know, my own personal health journey where I've had to grapple with my own understanding of pain and how I cope with it and how I manage it. And so that's kind of been the third parallel, I suppose, to my own journey.
Okay, so then a question that interests many for sure is how did actually CFT get developed throughout the years, and yeah, the original idea, how it was, and is it different from what CFT is now?
Yeah, so it probably comes from my personal journey partly, but also comes from integrating other knowledge into my own journey. So if you understand my personal journey, I first trained as a physio and I had a real interest in movement and watching movement. And I used to see movement as like biomechanics and anatomy. And then I realized that, you know, we were doing research projects. So in the early days, people like Wim Dankitz he did his PhD with me. And we had this whole belief, you know, I've written about this stuff around back pain's linked to instability of the spine. And, you know, there was this big focus on core muscles and all this kind of stuff. And we were looking at the EMG studies of these patients going, these people's back muscles are overactive, and their belly muscles, their core muscles are overactive. And, you know, they're demonstrating things that, you know, they might say, oh, I feel like my pain is unpredictable and it's scary and frightening. And we were like going, oh, well, you know, that's because there's some biomechanical fault. And we realized really quickly that actually a lot of these behaviors, so the way that people move with pain, is a behavioral response to pain. You know, I historically used to think it was like, this is about biomechanics and anatomy. And we realized that actually, you know, the behaviors that people adopt when they're in pain reflect other things, like the meaning of pain, like fear of pain, like avoidance of pain, or the threat of pain. And so what we started studying was really the behavior around movement in relation to pain. And so I kind of shifted my understanding around movement, or the embodiment of pain, is in terms of exploring what is it that pain means to you. And what we know in society is that, you know, back pain is really common, it's very disabling, and people fear back pain. And that when you have pain, if it's threatening, you'll guard and protect that back. And then those behavioral responses in themselves can set you up to create a vicious cycle where you have this belief your back is damaged and you're overprotected and you guard yourself, or you hold your spine rigid, or you brace your core and you start avoiding things that are good for you. And then you start losing function and you become fearful. And this vicious cycle sets up where your beliefs and your behaviors and your emotions then start fueling the cycle of pain and disability. And that's evidence-based in people's work, like Stephen Linton and Johan Vlijn's work around the fear avoidance model. And I think the key bit in that center was the embodiment of pain, is that these people embody pain, that fear is embodied, that you demonstrate fear in the way you move, the way you posture yourself, the way you guard yourself. And that bit was missing within the understanding of pain, is that there were these two kind of ends of a spectrum. The CBT is the counseling the people to counsel them to accept their pain and move on with their life and get to cope better. And then you got the other biomedical angle, which is to treat the pain and give pain, you know, like treat the symptoms. And there was this bit in the middle that was missing around, you know, the pain is embodied. It's an embodied experience, and that's something that we hold in ourselves. And so this missing bit was the functional bit. So understanding that cognitions are important for pain, but also behaviors are important and emotions are important. And the behavior bit, I think, was missing around a lot of the care of people with pain. So that's why we grapple with what do we call this thing? Because it takes from an understanding of pain neuroscience, it takes from understanding of cognitive behavioral principles, but it also takes from understanding that pain is embodied and that there are people's behaviors around movement in themselves can be provocative. If you overguard and protect a body part, you can create pain at that body part. That was the missing bit. So that's the F and the CFT.
Yeah. So in the beginning, you called it like classification-based CFT.
Yeah.
So
too much of a mouthful. People can't understand that. Like, it was a mistake, really. Sorry, carry on.
Yeah, yeah. So, but has it changed over the years? Like, really interesting story about how you ended up doing it. Yeah.
Yeah. So, look, the idea of classification, the idea was that you don't treat everyone the same. That that there are different patterns that you will see. So you could, for example, classify people around their beliefs as like really negative or quite positive. You could classify someone as very distressed or less distressed. You could classify someone as highly protective or not protective. So within each of these domains, or you could classify someone within lifestyle as really unhealthy lifestyle or healthy lifestyle. So there are spectrums within each of these domains that we know are important for pain. The idea of classifying people was to try and highlight that not everyone's the same, that each person is unique, but within each person there are different levels of importance within each dimension. We kind of move beyond that to kind of see it as more of a multi-dimensional framework, to say within each, it's more like I kind of use the analogy of a key lock or something, a combination lock, where each person, there are all these dimensions of a person and their profile. So you've got, you know, structure might be a factor, a dimension, cognitions, emotions, behaviors, lifestyle, physical, you know, these physical factors, health comorbidities, levels of sensitivity at each dimensions. And we know that people can differ on all of these different dimensions, and we need to target our care towards whatever the profile is that that person brings to us. So this idea of not everyone's the same, we can't treat them in the same way. But we dropped the name classification base because it was a bit confusing, and it made people think you can just plonk people in boxes, which you can't. Each person is their own unique set of factors. And so identifying them and personalizing them is much more around person-centered care for that individual.
Yeah. So I see quite many people still using the classification you published 2005. So what should they do with that?
It's life. So look, I think the things that we described, in those early papers, some of those dimensions are still helpful in my thinking, but I think we've just realized we had to move beyond that. And that's why that 2000 and whatever it was, 8 paper, 18 paper.
Yeah,
the PTJ paper was the update to the 2005 paper, which was much more about every person comes to us with a combination of factors, and we need to consider these factors across multiple domains and target those factors for that individual. And so having rigid subgroups is not really reflective. And in fact, Martin Raby published a lovely paper where he looked at things like, he looked at pain responses to movement, psychosocial factors, and sensitivity factors. So just 3 domains, and looked at whether people with chronic disabling or chronic back pain easily fit into groups and they don't. Like there's such a big spectrum. Human beings just don't nicely fit into groups. So you can subgroup people broadly across a single dimension, but once you look at multiple dimensions, there are too many options to do that. And then it just becomes confusing for people.
Yes. So coming from that history you just told us, so where do you see CFD going towards in the future? Yeah,
so the work we're doing now, so we've just completed a large randomized controlled trial here in Australia. It was a 2-center trial, and that compared CFT for people with disabling back pain to usual care. And we'll have the results of that trial. Well, we'll have the results at the end of the year, but it won't be analyzed and published until next year. That's a really important trial for us because it's probably it's well funded. It's a very robust trial. And it's multi-center. Something like 480 people have gone into that trial. So we have a lot of numbers, and it's in a really tough group of patients. So that's the patient group that, you know, often very disabled, who've been through lots of stuff and are not doing well. And we're interested in whether we can better care for that group, because there's very little evidence for long-term benefits of any intervention for that group. So we've got signals from our previous studies for long-term benefits in terms of reduction in disability in one study and pain and disability in another. But both of those trials were not that well resourced. This was been a fully funded trial, which meant that we put all the physios through a thorough training program, and we accredited them at the end of the training program that they were competent to deliver the intervention. And then we've done the intervention and we got this 12-month follow-up, and we plan for a 3-year after follow-up of that. And we're looking at everything from healthcare utilization to the economic benefits or not of this intervention. So that's a really important trial for us to go. We need to know where this sits within the healthcare landscape. Is this something that's worth pursuing or not, as a model of care? We're also involved in other studies around applying this model to, say, knee pain and hip pain and neck pain. So we've got other pilot trials that are running at the moment to look at taking that model of care from the back and applying to other body regions. And of course, if the trial looks like it's effective, then we're interested then in implementation studies to say, can you upskill clinicians in their own work environment to apply this model of care effectively in their own world? Because at the end of the day, that's the bottom line.
Yeah, sounds reasonable. Yeah. So still a couple of more questions about CFT itself. So yeah. How do you see, how is CFT different from some other approaches? What makes it unique?
Look, it depends on what you're talking about. So if you talk about comparing it to CBT, so CBT is very much it's more counseling or talking therapy. This is a doing therapy. So the talking bit is the data collection, or the interview, which looks at all the domains. The examination is the behavioral component, which explores the person's lived experience of pain and explores the way they move, the things that they avoid, their body responses to movement. So it's not just about the movement, it's about their embodiment of the movement, the way they move. So what we know about back pain is that people tend to overprotect the back, so they co-contract and guard their backs. And so Kevin Wernsley's work has identified that when you take people through this kind of process of change around relaxing their bodies and building confidence to take someone back to previously feared, avoided, or painful activities, and it's done in a graduated way, you can see these quite profound shifts, and that the less people guard and protect their backs, it looks like they can improve, both in terms of their beliefs, but also levels of disability and pain. So the doing bit is so important, and people I think misunderstand that this is not a hands-off approach. It's not a counseling therapy. It's a doing therapy. It's a therapy that builds people's confidence back in their body to engage with the things that they value, that they fear and avoid. That's a doing therapy. And from our qualitative research, it's the behavioral learning that looks like it's the key component of the therapy. The education stuff, so we educate people, but only within their own story. So we're not doing pain education as such. We educate them based on the story that they bring to us to help them make sense of their own story. So it's very different than a traditional pain education. We're not sitting there lecturing people. We're kind of reflecting back what their story is, and within that, their own lived experience of their pain, to help them back towards the things that they value, the things that their goals.
Yeah, and it's really important that especially the research is also focused on the people who are disabled, because they're often like excluded from the studies. But
absolutely. Well, if you look at exclusions, people are excluded for poor mental health, who are disabled, who are off work. It's like, that's the people who need our help. So the other thing around this trial, we know we've got people with who are in real trouble. So and same with Mary O'Keefe's trial, they included a tough group as well. What's also different in this the trial we're running now is we realized that you don't just finish care after a period of 12 weeks, that care needs to be continued. And so we've brought them back in at 6 months to do a booster session. So we're interested in that whole view around pain is like, you don't just finish caring for someone with chronic health problems. Someone with diabetes doesn't get treatment and sent away for the rest of their life. They're followed up, and their care plan is adapted. And if they have a flare up, then we have to address that. So I think we have to change the way we understand caring for people. Treatment's not done, care continues. And for some people, they need a higher dose of care. Others need a lower dose of care. Other people learn to self-manage. For others, they may find that they need to come back for booster sessions. So I think we need much more flexibility in the way we understand caring for people. And I think some of your work, Riikka, has been really helpful in understanding that too.
Yeah, sure. I think that's a big thing. We need big changes in the system. Are there some situations where CFT should not be used, or where it doesn't fit?
Yeah, so I think you want to separate the treatment from the multidimensional framework protects you. So within the multidimensional framework, you identify red flags, you identify specific pathology, and then where there's no clear pathology as a driver, then you identify the factors that are related to it. Now, I'll give you an example. I saw a young man about a month ago who came to see me with really severe back pain and bilateral leg pain. And he had had physiotherapy and dry needling and massage and tried Pilates and goodness knows what. And I looked at him and I examined him. He didn't have a neurological deficit, but he had a bilateral, straight leg raise of 10 degrees. He had highly guarded protective responses that were non-modifiable. So his behaviors were adaptive, in my view, to underlying pathology. So my approach to him was to say, I'm going to send you for an MRI scan. You're not someone who I can help. So CFT is not appropriate for him. And it came back, he's got this massive central disc prolapse that is non-resolved after a year. So he's going for decompression surgery. CFT is not appropriate for him.
Yeah.
That's so important to understand. CFT is not appropriate for malignancies. It's not appropriate for spinal infections. But for disc prolapse with radiculopathy, where there are adaptive responses and neurological deficits. So no, we don't use that. It's designed for people with non-specific low back pain, which is the majority of people with back pain. So is it got wide use? Absolutely, because that is the bulk of our people out there. So we know 95% of our patients coming through the door don't have red flags and don't have specific pathology, and they're the ones who become disabled and get stuck. That's who CFT is for.
Yeah. With those people that we're trying to help with CFT, so what do you think, which outcome measures would you say CFT has the biggest impact on?
Pain, pain, disability, number one, pain for many, self-efficacy, definitely, fear reduction, mood, getting on with their life. If it's anxiety and worry about pain, you should see those things dropping as well. And so the clinical trials that we've been involved in up until now will show that those things shift.
Mm-hmm.
Self-efficacy looks like, from Mary O'Keefe's trial, looks like it's a really important component. And that makes sense because we are about coaching people towards self-management. That is to build people's confidence to take care of their own self. And I think that's a key component of this intervention. Historically, as a manual therapist, my job was to treat people's bodies passively, and a bit of exercise and a bit of education, where CFT explicitly targets people to build their confidence back in their body, to engage with the things they value in their life, so they don't need me anymore. So if I'm doing a good job, they don't need me. And that's why self-efficacy is a really key target for intervention, to build, because people lose confidence in their body. I've just been at work today and I've seen 3 people who are young and very disabled, who've got no confidence in their body. And they've all been told terrible things. You know, you're just worn out. At the age of 21, you're just worn out, you got a disc bulge, you can't do your job anymore, you can't play sport. That is just wrong. You know, we are hurting people with that kind of information. And so what do? Well, you can't go to the gym, you can't lift weights, you can't do this. So then it comes with all this information that actually makes people frightened and disabled. So we don't subscribe to that. We'd say, look, you know, there are people around the world lifting and loading and training their bodies who have disc bulge and disc degeneration. And that is not a reason not to engage in living. In fact, we know you're healthier if you're, as long as it's graded, engaging with movement and activity and managing your whole health is good for back health. We hurt people by giving them nocivic information and unhelpful avoidance advice.
Yeah. So there was a question about whether there is evidence for keeping the neutral position of the back while moving and lifting. Yeah.
None.
That was a short answer and clear, as I understand. Yeah.
So, you know, it's interesting if you look at Nick Saraceni's systematic review, which got a lot of bad press. He looked at all the evidence around, is lumbar flexion a risk factor for lifting? And there isn't any evidence. Now, that's not saying that you can't sprain your back, flexing your back, because of course you can, but that's no different. I see it's just the same as saying, if you went for a run, could you sprain your knee? Yeah, what's the chance of you spraining your knee if you went for a run? Well, if you're really deconditioned and you're carrying an extra weight and you aren't used to running, then running may hurt you. Right? So if you're really deconditioned and you're not used to lifting and bending, and you've got poor conditioning in your body, and you go and do a whole lot of lifting, you may sprain your back. But that's no different than any other body part. Yeah. But if you're conditioned to lift, if you build your body's ability, your fitness and conditioning, and you care for your whole health, you can minimize the impact. We just don't have any evidence that there is a better way to lift. What we do know from a recent paper that just was published is that lifting with a round back is more efficient.
Yeah.
So if you're going to do a lot of lifting with a straight back is probably more fatiguing. And if you're going to do that all day, then what it looks like is actually you can't sustain that. Now, that's not saying lifting with a neutral back is bad, but if you teach in a way that induces fear, that could be unhelpful.
Yeah.
It's a bit like saying to someone, you know, be careful when you're with your foot straight when you run. It's like, well, we know that there is all kinds of ways that you strike your foot when you run, and one's not better than the other. It's about whether you're conditioned to it and whether you're efficient with it.
Yeah, sure. Then there was a question, what is your thinking around movement control exercises nowadays?
So my view on what the best exercise is the exercise that rapidly takes people to build their confidence so they don't have to think about their back when they exercise. So we have to be careful we don't create too much vigilance around the back. Building confidence around the task may mean that you focus your attention away from the back. And if you think about probably the big thing that when I work with people with back pain, the key drivers of the lumbar spine are the pelvis, that's the hips, and the thorax. So often we're training people to focus their attention away from the back, not the back itself. And that's good because it shifts vigilance away from the back, because people with back pain spend a lot of time thinking about their back. and it doesn't make them feel better. So my view on movement control exercises is make them functional, make them challenging, and build people's self-efficacy. So make them linked to patients' goals. Don't give people a whole bunch of exercises that are not related to their goals, because that doesn't make sense. So if you want to run, you can't train running by swimming. Mm-hmm. If you want to learn to lift, you've got to lift. So teach people to do stuff they can't do, or they're frightened, or that they're avoidant of.
Yeah. Then there was another question about exercise. This is a long one, so I'll read it out loud. So my understanding of CFT is that an important focus is based on the interview to find aspects or postures or movements that possibly provoke pain and that might be related to a belief, emotional reaction such as worry, fear, or avoidance. And through discussion and exposure to movements, the idea is to create a new understanding of pain and find ways to do those things or movements that have previously been challenging. The question is, how big a role do you see structured programs that focus on developing strength or endurance have, or is it more about the aspects mentioned earlier? So what I'm trying to ask is how you plan exercise programs for your patients.
Yeah, okay, so that's a good question. So where there are provocative postures and movements which are a roadblock to getting back to functioning, then addressing them. It's kind of like, what are the roadblocks? So if the person says, like I saw a person today who wants to run, can't run. Every time she runs, her back locks up. So it's like, okay, we need to look at how you load your left leg. Are you confident to load your left leg? Are you overprotecting your back when you load your left leg? And examine her, she's like so weak on her left leg, and she's got no power on it because she's been avoiding loading the left leg. So there is a protective element and there's a deconditioning element. So in terms of managing her, part of it is exposure, is part of getting her to get on that leg and work that leg and build that strength back in a way that builds her trust in that leg while relaxing her back so that she realizes that it's trustworthy. So that's not one or other, it's integrated towards her goal. If someone's not deconditioned, then conditioning them doesn't make sense. But if you've got someone who wants to go back and be involved in a manual job and they've been lying at home all day, you have to condition them to that job. So if you want to run a half marathon, you've got to work on a training program towards a half marathon. So it's kind of all about goal orientation. If the person says, my main problem is I can't sleep at night and when I roll over, I hurt, that's not a conditioning program. That's about understanding what the mechanisms are when that person's in bed, where they overprotect their body or whatever they're doing, targeting that. So it really comes back to the person's presentation, their capacity, and where their goals are. Because if their goals are in engaging high level activity and load, invariably you have to train them in that process. The key thing is there a roadblock? If the roadblock is beliefs or emotions or fear or protective behaviors, then addressing them unblocks that system to get them back to doing the stuff that they want. Now, sometimes you can just take them there, and other times you have to work with them in between.
Yeah, I think that makes sense. So now if we go a little bit to how to learn CFT. So there's a question that to become good in CFT requires quite a lot of training. So how to learn it?
So we're doing research on this at the moment, as you know, and part of your PhD kind of looked at we've kind of looked at two levels of learning, I suppose. What we understand is you can, it's like changing human behavior. It's really kind of hard. If you're being taught to think in a certain way, CFT sounds like it's like, for someone who believes that the world's flat and then someone says it's round, it seems like that's a big jump. But if you already thought the world was round, it's just not such a big problem. So it really depends on the mindset and the skill set of the person when they come to it. So if they're thinking pain is very structural, biomechanical, it's a much bigger shift for people. But if they see pain within a biopsychosocial construct, then it's a much easier shift. So it really depends on the starting point. as to where you have to go on that journey. So we see every therapist as comes with their own strengths and weaknesses, like our patients do. And that journey looks different for different people. And so as we would personalize our care plans for our patients, we would personalize the training plans for the therapists. And so within this trial that we've run, we've piloted a training program which really looked at individualized targeted feedback around us watching clinicians work with people with pain, and then reflecting on that and videoing it and giving point direct feedback and then training again. And that was an iterative process over a period of months. This trial will test whether that worked, I suppose. And so the answer is we've got research, and we've got, as you know, Phoebe Simpson's been involved or is involved in some qualitative work interviewing those therapists to say, how was that journey for you? Was that helpful? Were there other things that could be helpful? So all of this research is trying to help us understand how we can best equip clinicians for change. What we know is that to go to a lecture, it's pretty unusual for you to be able to just flip how you practice by just listening to someone talk. It's a doing thing. And we know from any skill training, you need observation and feedback for that skill training. So opportunities at the moment are, we haven't rolled out a training program because we're still in this process of evaluating it and then evaluating whether it works in terms of the efficacy of the intervention. So these are all things that we're not just jumping out and putting out there, but things that we're interested in researching, so that if we do promote a training program, it's an evidence-based program, not just something that we cooked up and thought was a good idea.
Yeah. What if a clinician is at the moment, they have been reading all the articles and they watch all the videos and listen to your podcast. So at the moment, if they are willing to learn, so what can they do? What do you think?
Yeah, so at the moment, as I said to you, we have deliberately not promoted a high level training program because we're in a process of assessing the efficacy of it. Yeah. And I know it frustrates some people, but you know, as a researcher, I've been very reluctant to over promote something without sufficient evidence. Yeah. And you know, I think that's a very honest, and it's also about, you know, we don't want to waste people's time and resources selling them something that they then go, well, that's no different than going for a walk. You know, like, that's just about doing the right thing. So, you know, we aren't a business. We're not selling a product. We're about developing knowledge to help people with pain and to help clinicians help people with pain. And so we will take our time to determine whether this is the right approach before we implement that.
Yeah. While waiting for that, would you see as beneficial to go for to learn some communication strategies or motivational?
Yeah, absolutely. And look, we do run the odd, like, what people in our group are doing some workshops. So I'm doing an online training workshop in June. It's the first one I've done, so it'll be interesting to see how that works, because normally they're face-to-face, but in the COVID environment can't do that. And what we're doing at the moment is filming patients' journey, so it's real. Because one of the things I know that came out of your one of your papers and others have criticized is that bringing a patient into a group is not a normal environment, and there's the potential for a stage effect and all that kind of stuff. So what we're doing at the moment is actually filming patients who are seeking our care in our consult room. So it's a natural environment. There's no crowd, and we can then capture the journey of those people over time. So we've not pre-selected them. I've not met them. They're pre-selected on the basis that they have disabling pain and they're seeking care. Yeah. So part of that will be to track their journey, and that's part of what we will use as you know, material for learning.
Yeah, that sounds good. Then there is another question about learning. I'll read it out loud as well, because there are many questions in the same. So if CFT training is meant to develop better physiotherapists, how can this development be seen in better management outcomes, less appointments, treatments needed, less recurrences, better patient satisfaction, something else?
Yeah, they're all things we're measuring.
Yeah.
They're all the things we measure. So, you know, bottom line is if it doesn't do those things, then don't do it.
Yeah. So if every physiotherapist of the world would use CFT, so would it decrease the prevalence of low back pain?
I don't know. You know, the problem we've got in our health system is we've got so many mixed messages, right? So you've got people telling people you've got a rotten disc, you've got a disc bulge, you need to be careful, you can't do this, you need to be careful. So the patients themselves have grown up in a society where they're being taught to fear backs. They know people who have been disabled with back pain. There is so much fear in our society with backs. So I think we need a multi-prong approach. I think the best way for something like CFT to flourish is where it's linked to educational campaigns, where it's linked to educate patients around the facts versus the myths of back pain, where it's linked to a whole change within the health system, where the GP and the surgeon and the pain specialist and the physios and the psychologists are all speaking the same language. If we can do that, and we have funding systems that adequately fund good care and defund crappy care, if we could do that, you could have a massive impact, I think, on the health system. But I think just to upskill a practitioner when the patients have so many contradictory messages that are fear-inducing makes it a very hard job. And that's where we see this model of care can only flourish within a bigger system change.
So yeah, I think that's what we need, just by changing professionals. So we're not making.
But that's not to say you can't change the system if you don't upskill people to deliver a different model of care. So it's all very well to change the funding in the system, but if you haven't upskilled people, then you've also got a problem. So it's got to be hand in hand, I think.
Yeah, exactly. Yeah. So one barrier that we've seen is the like training and learning of psychosocial issues. So how would you think of training physios towards that? What would be the key thing?
I think the issue around psychosocial factors is we know that physios don't feel comfortable. They feel like it's beyond our scope of practice. They haven't been well trained in it. My view on this is that for a lot of people, if you put yourself in someone else's shoes, if someone says to you, if you're a 21-year-old and you want, your job is a manual job and you want to play a sport, and someone comes along and says you've got a rotten disc and you'll no longer be able to do that in your life, how would you feel? Like you would feel like shit, and it would make you worried, and that would make you stressed, and that would get you down. That's normal. Yeah. So the messages that we give people with back pain, the consequences of that are often distress. That often impacts their mood. It makes them worried. So our role is not to become psychologists. Our role is to create hope for people, to give them strategies to get back to the things that they love, to reduce their worry, to give them tools to build this self-efficacy so they can self-manage. And a lot of those things may reduce. Now, for some patients, they need also integrated care with the psychologist. So we are then working in parallel. So we might be working on some of the lifestyle and physical domains while and around their fear of movement, while the psychologists work on some of their psychological or social factors that are big players in their life. So we know a lot of our patients come with a lot of history of trauma or social stress or other life difficulties that they just need better support. So my job as a physio is not to treat people with underlying primary depression, panic disorder, who've had a history of traumatic, physical trauma or sexual trauma or whatever. My job is to work in a team of people who can more adequately support those patients. So I think we've got to be really clear around our scope of practice. There are lots of patients who are distressed and are frightened and are worried and are down because they've just been poorly cared for. And there is another group who have comorbid mental health problems who need, integrated care with psychology and medical care.
Yeah. So on the other hand, how big a role does bio play in CFT?
It depends. So I just gave an example of someone who, directly was sent off for a scan. I see people with degenerate discs with modic changes. That's bio.
Yeah.
Everything's bio. Your mood, your sleep changes bio. Your movement changes bio. Your protective behaviors change bio. You cannot separate bio from psycho and social. And that's what shits me, is that there's this dumb dichotomous separation that somehow the head and the body are disconnected. It's so dumb. Like, you have a bad night's sleep, it will affect bio. Your mood is flat, you will affect bio. You're worried, it will affect muscle tension in your body. You brace a muscle, it changes bio. You're deconditioned or eating shit or drinking too much or sitting around all day not moving changes bio. We are biology.
Yes, thank you. This was well said.
It does my nutting.
Yes, I can see that this frustrates you, and it frustrates me as well. Okay, then there's another question that I will read out loud from here. Okay, sometimes just a couple of appointments with my patients have been enough to find different ways to, for example, bend and lift things by relaxing tummy and back, breathing, rounding the back, and so forth, and by slowly increasing the load. And this has had good results. No more problems with bending. Is this enough training, or should something else be done? Of course, following patients up and possible booster sessions may be needed. Just trying to understand the planning of exercise and self-care for patients. And yeah.
So my view is, why did they come to see you? What are their goals? Have they achieved their goals? So if their goal is, I want to be able to bend and touch my toes, or bend and lift and bend and pick stuff up, and I want to garden, and I want to be able to go and dig a hole and pick up my kid and throw the kid in the air and do all those things, then I'd be going through that list before I discharge someone and said, let me take you back to your goals. You told me at the first session you wanted to achieve A, B, C, and D. Are you doing that? If not, why? What do you need to achieve that goal? Do you have more goals? Or I'd say to them, is there anything in your life at the moment that you're avoiding that you want to be doing because of your back? What is it? Let's reframe the goals. So, because goals often shift. So people coming in hoping for a little bit, and then they start getting brave and they hope for a lot. So the key is to go back to the person's goals. It's person-centered care. So it's about their agenda. So let the patient set the agenda, not you.
Yeah. There is a question actually related to this. Someone asked for more ideas for clear movement progressions for different movement patterns that were presented during CFT workshop.
Yeah, look, the patients bring the progressions in, don't they? So it's like, what do you want to do? So if you want to lift. If you want to run, you got to practice running. You got to build up load tolerance and capacity and confidence around loading the limbs. And it's like, it's really kind of common sense in my view to go, what is the goal? If the person's goal is, I want to be able to relax when I sit, you got to practice relaxed sitting. If your goal is, I want to roll over in bed without pain, you got to practice rolling. So the exercises are person-centered, and they're about breaking down a movement pattern and building it up. I see it no different than it's like rebooting a developmental sequence. How does a child learn to move? Well, they learn basic building blocks of movement. Pain disrupts those building blocks. So it's like you take people back and you reboot the system, taking them back to very simple, functional, repetitive tasks and build people's capacity up. And they're movements they've learned before. They're not learning for the first time, they're learning again.
Yeah, sure. Then I think an interesting question. What are the most challenging situations with the patients you face?
Oh, look, I had one today, and that's someone who's been told by a doctor that they're back stuffed and they're 21 and they'll never be able to, play sport and do their job. Like, that's just a shocking thing. And he's seen the scan, and he's got a degenerate disc and a disc bulge. He's got no neurological symptoms at all. That's like a mass in no see, but that's a belief that this young man is adherent to. The only way you can shift that belief, I believe, because he's so stuck on it, is to demonstrate for him that his body is trustworthy. And that's about that's him trusting me to take him through an experiment. That's really tough. The other tough groups for me are people who are under huge social stress, like got so much stress in their life that is just overwhelming them, and so pain is just part of a whole lot of other stuff, and they don't have the mental, emotional, or physical or financial resources to prioritize their own care because their resources are being taken up with all that other stuff. And comorbid mental health problems would be the other one. People who have had early life trauma where they're just very vulnerable and they're very highly sensitized. So people are highly sensitized where everything hurts them. Other people I work closely with medical and psychological support. They're our biggest barriers. Fear is usually relatively easy to manage, but high social stress, significant comorbid mental health, previous history of trauma, mainly, sexual, physical trauma, that kind of stuff. That's really tough. They're really people who have a very hard journey in life, who we need to care for very well as a society, and I don't think we do.
Yeah, I agree. Related to the first example, so there is a question about the beliefs. So are there situations where we should not try to change the beliefs, meaning that are some beliefs so benign that we just should let them be and not trying to change them?
So the only time I would challenge someone's beliefs where it's an obstacle. So if your belief is you shouldn't bend and lift, and you can't live doing that. It's just, you can't live. If you believe that you shouldn't ever run, but you don't really want to run, don't worry about it. But if you have to run across a road because you're going to be hit by a truck, that's pretty important. You can do that. So, it really comes down to what beliefs are an obstacle for that person. I think, but we know that you can hold a latent belief that may become a problem at a future point in the person's life. So a lot of people have beliefs that don't affect them at all. Bad beliefs about the back don't affect them whatsoever until they have an episode, and then those beliefs become relevant. And so these beliefs in our system are lurking, ready to raise their head at a certain time, and then they could become a problem.
What if the belief is an obstacle, but it's so big part of a person's identity, or it's so strong? So are there situations where you just should let go, or are you still trying to change it?
No, look, I don't really try, and I never lecture people into changing their beliefs. I might use other people's stories, but usually it's through their own experience. That's what I would use. So that's the nature of reflective questioning and motivational interviewing, is to make them use their own experience to learn through their own experience, so that they come up with their own answers instead of me having to tell them. That's the best way.
Yeah, I agree. Couple more questions. In your opinion, what kind of barriers are there that make it challenging to work with CFT? You talk about already some.
So time. I think you identified some of these in your study as well. I think time, your environment. If you're we talk to a lot of physios who say, I work in an environment where everyone's doing something completely different. It's really hard for me to deliver this level of care. While I work in an environment where everyone's behind curtains, I can't ask sensitive questions because they're in a public area. I can't do that. I had someone today literally telling me about that. Time. I work in an environment, I have to see someone every 15 minutes. You can't do that. Like, you just can't. Training, like I've got no confidence because I've got no training and skills. That's a barrier. They're all different kinds of barriers. So that comes back to the system versus the training thing.
Then about manual therapy, the favorite topic always. So how would you talk about manual therapy to your patients? For example, if there is somebody who has low psychosocial profile, they're already active and their lifestyle is fine, and they come to your appointment and they just want to have some manual therapy for pain.
Go for it. Go for it.
Yeah. How would you like?
Like, you know, the people who I'm very reluctant to use manual therapy on is people who are disabled, people who've got low self-efficacy, people who are frightened. And if I do use manual therapy, I'm really honest about it to say, hey, you know, the only reason I would use manual therapy is if you, let's say there's a person and in the process of trying to facilitate their ability to move, they were so guarded and protective that using some kind of manual technique just was to use to teach them to de-threaten, to relax their body. But I'm not telling them that I'm putting something back in. I'm not telling them that I'm fixing a dysfunction. I'm just talking to them about the fact that, can you feel how tense and guarded you are? And what do you notice when we work with your body? And as you breathe and you move, how does that feel? It's like, oh, it feels better. So all I'm doing is giving your body the confidence to move. Now, this will not benefit you in the long run unless we now teach you how to do that yourself. So the most important thing with manual therapy is it's not a treatment in itself. It's an adjunct, and it's not a necessary adjunct. So within our trials, we've actually not included manual therapy purely for the reason that we didn't want to confuse the intervention, because I don't think it's necessary. It may be, it's an optional extra, but it's not the main game. And that's someone who has trained as a manual therapist, who can crack any joint in your body. And I use manipulation, I certainly use less and less and less. I touch everybody that I see unless they explicitly ask me not to. And there are some people who've had bad experiences of being touched, and they will come in to see me and say, please don't touch me. And of course I respect that. Although some people are really frightened, and through the course of that treatment, them trusting me to touch you over that time might be an important part of their therapy, to just de-threaten that it's okay to be touched. But touch is about feedback. Touch is about care. Touch is about empathy. It's about facilitation. It's about education. It's about building confidence. I use touch with all my patients, but and as a trained manual therapist, I'm skilled to touch people, and I use it because we know it's a potent and powerful means, a therapeutic opportunity. But I'm very clear that it's not the touch that is the care. So that it is the person themselves and their ability to build confidence in their body. That is the most important thing for me to impart with them. Because we get trapped, and I have been trapped as a manual therapist, where people come back for the same damn thing and they don't change. And it's a horrible trap to be caught in. And I have been caught in that trap.
Yeah, I see that. A couple more general questions. What questions would you like to see future research answering?
Oh, where do I start? Future research. Wow. How do we help change systems? How do we help, you know, build change beliefs in society? How do we change the way people look at back pain at every level of society? That's a great question, but it needs huge resources. And look, you know, I don't see this as a panacea. Like our goal is not to eradicate pain, because that's not a realistic goal. Our goal is to reduce the burden of disability that pain has on people's lives. I have pain every day in my body. It doesn't worry me. It doesn't limit me. It doesn't stop me from doing a single thing in my life. That's a goal. So, you know, we've got numerous research projects that are around, and I think the biggest stuff around now is around developing implementation studies around better caring. I think we have so much knowledge about what we do, but we do so little of what we know we should do. So upskilling people to do it, empowering them to do it, getting health systems to support people to do it, shared messaging, integrated care, so that GPs, I've said this stuff before around, that's where I think really important research has to happen.
Yeah, yeah. So one more general question. So is there an acute condition that physiotherapy can cure faster than natural healing does?
I'll kind of see it differently to that. You know, persistent pain isn't about healing. So the barriers to recovery, we know that if you hurt your back, the majority of people, 70% are going to get better no matter what you do, right? I don't think you can, well, you might better speed that up, but it really depends on how the person behaves. So if the person's overprotected and overguarded and they rest too much and they become fearful, then we know that pain can persist. But that's not about tissue healing. That's about obstacles to recovery. So I don't think it's helpful to think around tissue healing. And you know, that presumes there was an injury in the first place. And the majority of back pain isn't an injury. The majority of people who hurt their back lots of people who hurt their back can't even tell you what the injury was. So in fact, I was just in a lecture last week, and there were 22 people. Everyone has had back pain. Only one of them had an injury. So this idea of acute pain being related to, you've got to have a history of an injury to be injured.
Yeah.
So can I speed up someone's healing? No, it's like the body has a natural healing capacity. Can I optimize it, create the best environment for it? Yeah, I think we can, around coaching people, around positive mindset, around graded activity, around engaging with living again. Yeah, you can speed that up.
Yeah, yeah.
But that's more, it's not speeding up the healing process, optimizing it, but it's really about helping people not get stuck with those common barriers to pain persistence.
Yeah, yeah. So then a more personal question. Do you even lift bro? And how much do you lift from the bench?
Did I what?
How much do you lift from the bench press? How many kilograms?
I'm not really into weights, to be honest with you. So like I'm into outdoor activity like mountain biking, and I'll mountain bike, swim, rock climb, hiking, walking my dog. So I don't really like gyms. I mean, I've got some weights that I'll push out, lift outside, but you know, if there's some 10 cubic meters of mulch, I'll dig that in the garden in a weekend. But I'm not a gym guy. So you won't see me on Twitter posting pictures of myself lifting weights, put it that way.
Yeah.
But if I went into a gym, how much weight would I be comfortable to lift? Probably a weight that I feel like I'm conditioned to lift.
Yeah, yeah, that's a good answer. Yeah. Okay, then the last question. 3 must-read books for newly graduated physiotherapists, or something else to read?
Oh, find a mentor, keep an open mind, go on a learning journey, have a positive mindset, read as much as you can, take time, self-reflect, you know, critique yourself, listen deeply and care deeply for your patients. That's what I would say. Do that. Yeah.
That's a good advice for everybody, I think.
I think so. It's what I've done for myself.
Yeah.
And learn from your failures, because my failures have been the things that have taught me the most, I think, in my career. My clinical failures, my, you know, academic failures, my, you know, those things we can really learn from.
Yeah. So is there something else you want to say that I haven't asked you? No, I think they're great questions, and they're questions that I ask myself all the time. I'm always reflecting and learning, and part of our group has a growth mindset. So we're interested in feedback, and we're really interested in improving people's care in the long run. And, you know, I'll be the first person to come up and say, we need to change this if the evidence tells us we need to change it. Yeah. So if, for example, this approach is not helpful for someone, I'll be the first to identify that and
to listen to it and self-reflect and shift. And that's why I think you have seen this approach evolve over a long period of time. But the fundamental thing that is central to this is the Therapeutic Alliance. If you don't have a strong Therapeutic Alliance, nothing works, in my mind. So the patient relationship and trust is the key, because if you have that, you can take people on a journey. But let the person drive that process. I think it's so important, so that it's about the patient's agenda, not your agenda, that drives that. I think that's really important.
Yeah.
And we got to get way better at listening to people and you know, listening to their perspective. So it's about them, not about us.
Thank you so much for your time and insights. This is, I think everything you've said is so important for us as a profession, or also others than physios can learn from this. So amazing opportunity to sometimes, usually you are the one who's asking me the questions when I make something better in my research. So now I had the chance to ask you questions. So this was nice.
Yeah, and just to also, the last point of comment there, Riikka, is that you have taught me a lot in your research journey. And I think the work that, you know, I was a bit of a reluctant participant in coming to Finland, but actually your research has been a highlight from that that time in Finland, because it's actually given us a lot of really helpful insights that we have and will use to understand what we're doing better. And I think that's the most important thing, is that it's never about a single person. It's about, we have to get away from, this is not about CFT. This is about the person. It's about what tools do we have to help a person on their journey. And if there's a better way to go, I'm the first guy to put my hand up to go, we need to do that. So I do not have a personal investment apart from looking at taking people on that journey. And that's what I do 3 times a week. I'm with patients who have been really disabled with pain. I work with them all the time. I have people who I know I struggle to help. I have people who can transform amazingly and quickly. And we need to know more and more about the people we can't reach. They will be they'll be the teachers for our next journey, I think. And that's not just me. There's a whole team of people around us who are involved in that, and not just with our research group as well.
Yeah, and I think that's such an important thing, the international team that you've been able to create. It's a real powerful thing around CFD, as you said, with others as well. So I think that's a big thing.
Absolutely. And look, you know, I think it's so important to acknowledge that. Like, I've got an amazing team of people here at Curtin who just have enabled me to do the work I do, but it's an us, not a me. So this is not about me. This is about a whole team thing.
Yeah, so we can learn together. No one can do it alone.
No, exactly right.
Yeah. Thank you so much, Peter.
It's a pleasure. Lovely to chat to you again.
Yeah.